Glaucoma Society of India, the Glaucoma Crescendo. I request the President of the Glaucoma Society of India, Dr. S.S. Pandav, to please give the welcome address.
Thank you, Dr. Chandra, for organizing this webinar. And on behalf of Glaucoma Society of India, it's my pleasure to welcome you all to this international webinar on glaucoma. This evening, we will be talking about OCT in glaucoma. As you know, OCT is a quick and non-invasive way of imaging the eye and has become a very standard, very frequently used and almost a standard practice in glaucoma in diagnosis and management of a number of ocular conditions, in fact, which includes age-related macular degeneration, diabetic retinopathy, and of course, it's increasing use in glaucoma management as well. Today evening, I am very delighted to welcome Professor Joel Schumann to this meeting. As many of you would know, he is the inventor of the OCT technology, and he has been associated with this work for a very, several decades now. And we are seeing the fruit of his hard work. I don't think you can get a better person to talk about OCT than him, and we are very fortunate that he is with us this evening. Currently, Joel is Alain Langone Professor and Vice Chair for Research in the Department of Ophthalmology at New York University, Langone Medical Center, and New York University Grossman School of Medicine. He has also served previously as chairman for the same department. On behalf of Glaucoma Society of India, Joel, I extend a very warm welcome to you, and also thank you very much for sparing of time for us and sharing your experiences and insight about OCT today. I would also like to welcome our panelists this evening, and we have Dr. G. Chandrasekhar with us, popularly known as GC. He is the Vice Chair at L.B. Prasad Eye Institute, Hyderabad, and he's also the Director of Education in the same institutions. He holds the position of Clinical Professor at the University of Rochester and has been visiting professor at the University of California, San Diego. Dr. GC has also served as President of the Glaucoma Society of India. He's always had the benefit of the society and benefit of the patient always in his heart, and he's always there to guide the society and always comes up with very good suggestions. Thank you very much, Dr. GC, for your guidance, and also I welcome you to this meeting this evening. Professor Ramanjit, she's not joined yet, but I'm sure she will be joining us, sooner. She is heading the Glaucoma Research Facility and Clinical Services at Dr. Rajendra Prasad Center for Ophthalmic Sciences at All India Institute of Medical Sciences, New Delhi, India, which is a leading institution in our country. She is on the executive board of a number of committees, including the International Glaucoma Research Society, World Glaucoma Congress, Asia Pacific Glaucoma Society, and many others. And she also has served the Society Glaucoma Society of India as the president. And she has actually been the founding secretary of the Glaucoma Society of India when it came up in early 90s. Professor Ramanjit is very passionate about reaching glaucoma patients in the community, and she has been spearheading a national task force in glaucoma to improve the diagnosis and therapy of glaucoma across the country. We also have a senior member, Professor J.C. Das. He was the director, professor at Guru Nanak Eye Center, Maulana Azad Medical College, New Delhi. And he is actually introduced and popularized glaucoma valve surgery in mid-90s, I think, when the valves came first to India. Currently, he is a senior consultant and chief of glaucoma division at Shraf Eye Hospital, New Delhi. He has been a visiting professor to Karl University in Germany, and he has also been president of Glaucoma Society India and also Delhi Ophthalmology Society. Welcome, Dr. J.C. Das. Thank you very much for joining us this evening. We also have Dr. Harsh Kumar among the panel, and Dr. Harsh Kumar has been additional professor at Dr. R.P. Center on Institute of Medical Sciences, New Delhi. Currently, he is a senior consultant at the Center for Sight in New Delhi. He is a brilliant surgeon and has contributed a number of innovative procedures in surgical procedure as well as laser procedures for glaucoma. Dr. Hirsch also served as president of the Glaucoma Society of India in 2010. He has been bestowed with Padma Shri Award, which is the highest civilian, one of the highest civilian awards in our country, by the Government of India for his meritorious services in the medical field. Dr. Nangia is not been able to join us this evening for his personal reasons. We have Dr. R.K. Ramakrishnan. Thank you, Dr. Ramakrishnan, for joining us, and I welcome you to this meeting. Dr. Ramakrishnan is popularly known as RK, and he has been the chief of Glaucoma Clinic and chief medical officer and professor of ophthalmology at the Arvind Eye Care Hospital, Tirunelveli. Currently, he is the advisor to Tirunelveli Hospital and chief of glaucoma services at the Arvind Eye Care system. He was instrumental in establishing glaucoma services at the Arvind Eye Care Systems in Madurai, as well as Arvind Jai's Center for Excellence in Glaucoma at Tirunelveli. He served as president of the Glaucoma Society of India from 2002 to 2004. And finally, we have Dr. Krishna Das. I think he's about to join. He has been head of the clinical services in the same organization as Arvind Eye Care Services and medical officer there. Chief Medical Officer, and currently he serves as the Director of the Human Resource Department, and he has also been the President of the Glaucoma Society of India. So I welcome you all to this meeting, and I also welcome all those the participants who will be joining us online and or through social media. You are all welcome to this evening, and I am sure the interaction with Professor Joel Showman is going to be very useful, and this will be an excellent experience to as far as OCT is concerned. As I mentioned earlier, I don't think there's anyone better than Joel Showman to to talk to about OCT, particularly in glaucoma. With these brief introductions and welcome, I hand over the mic to Dr. Chandrima Paul, the Honorary General Secretary of the GSI, to formally introduce our guest speaker of this evening. Dr. Chandrima, please.
Thank you very much, sir. And I'm just sharing my screen. So very warm welcome, Dr. Joel S. Showman, MD, FACS. Dr. Joel S. Showman is the Elaine Langon Professor and Vice Chair for Research in the Department of Ophthalmology and Professor of Neuroscience and Physiology at the New York Langone Health and New York Grossman School of Medicine. He is the Professor of Biomedical Engineering and Electrical and Computer Engineering at the New York Tandon School of Engineering and Professor of Neural Science in the Center for Neural Science at the New York College of Arts and Sciences. He chaired the Ophthalmology Department at the New York Langone Health, New York Grossman School of Medicine from 2016 to 2020, and at the University of Pittsburgh, UPMC from 2003 to 2016. At Tufts University from 1991 to 2003, he was the Residency Director and Glaucoma Cataract Service Chief. Dr. Showman and his colleagues were first to identify a molecular marker for human glaucoma published in Nature Medicine in 2001. Continuously funded by the National Eye Institute as a principal investigator since 1995, he is an inventor of the household name today, the optical coherence tomography used worldwide for ocular diagnostics. Dr. Showman has published more than 400 peer-reviewed scientific journal articles. Dr. Showman has received numerous awards and is a 2012 Champollion Award laureate. The Champollion Award is often referred to as the Nobel Prize for Vision. Today is actually a dream come true for me. That's when I met Dr. Showman at the American Academy meeting where I presented a paper on OCT, and he was chairing that session, and had the privilege for the first time to talk to him on the OCT. I was then a young member of the GSI and was waiting for the day when GSI would host Dr. Showman. And finally, after almost 2 decades, we are able to host him today. And hopefully we would host him physically sometime in the near future. With these words, a very warm welcome to you once again to the Glaucoma Society of India and at the Glaucoma Crescendo. Thank you. Over to you, Dr. Showman. Go ahead. It's all yours.
Okay, thank you very much. What a great welcome, fantastic introduction, and I very much appreciate the opportunity to be speaking for the Glaucoma Society of India, and I can only wish that I was physically there. That would make it perfect. It's an honor and a privilege to be part of your meeting and to be on this very illustrious panel with many of the former presidents of the society as well. I'm going to speak about advances in OCT for glaucoma, and this talk is arranged as initially clinical and hopefully with some ideas that you can use yourself or may even be using now in clinical patient care. And then I'm going to talk a little bit about what's happening in the laboratory and what might be on the way in terms of OCT. These are my disclosures. And I'll start off with something very simple, and I'm sure that everybody in the audience is already aware of this, but in case there are some residents or fellows or trainees or non-glaucoma specialists attending, this is an example from an article of a couple of kids playing. Their ball ends up running into the street, and they're running after it. And this is what somebody with a normal visual field would see. So the visual field's on the bottom left. And so you might see well in advance that there are 2 children running after a ball. But somebody with glaucoma might miss these children altogether and not realize that they're missing those children because your brain fills in the area that you are not seeing. And so this is somebody with, maybe a mild to moderate glaucomatous defect, but because of that glaucomatous defect, this person would not see the children running out into the street and not realize the danger that they're driving into. So that is just to give an idea of what the person with glaucoma is experiencing. And I'll give 4 facts about glaucoma. It's the second leading cause of blindness. There is no cure, at least not yet, for glaucoma. Everyone is at risk for glaucoma, and there may be no symptoms to warn you. It affects 80 million people worldwide this year, and it's expected to exceed 111 million by 2040. And over half of all the glaucoma cases, at least in the United States, have not been diagnosed. That proportion is higher in some areas and perhaps lower in some others. The average age of onset is 54 years of age, and most patients have had glaucoma for more than 10 years by the time that they're diagnosed. And because there is no cure, we depend on treatment to stave off blindness in glaucoma. And this retrospective study from over 20 years ago now looked at people in Olmsted County, Minnesota. And so these are people who were being cared for at Mayo Clinic, which is an excellent institution. And yet the probability of blindness after 20 years was 27% in one eye and 9% in both eyes. And of 114 patients initially treated for ocular hypertension, so they had no detectable optic nerve or visual field damage, the probability of blindness after 20 years was 14% in one eye and 4% in both eyes. And this points out the importance of detecting glaucoma early and treating it early, as well as detecting progression early and treating it early in order to prevent blindness. So let's talk about the clinical use of OCT in glaucoma. This is from a study that we published 10 years ago now, looking at the structure-function relationship in glaucoma. And what you see is that when the nerve fiber layer is thick, that there's very little relationship between structure and function as we measure it with visual fields. But you reach what we call the tipping point, and below that tipping point, when the retinal nerve fiber layer is thinner than that tipping point, there's a strong relationship between measurable function with visual fields and the retinal nerve fiber layer thickness. And we found that tipping point to be about 75 microns for the mean overall nerve fiber layer thickness, with a confidence interval, 95% confidence interval of about 69 to 82 microns. And that indicates that a person can have thin nerve fiber layer and have a normal visual field. And so this thing that we used to call pre-parametric glaucoma, we can now detect and diagnose accurately by using OCT. And let's look at this schematically. So when the retinal nerve fiber layer is thick, we can measure abnormalities primarily in structure by OCT. And then you reach a tipping point at about 75 microns, below which, up to about 55 microns, there's a strong relationship between the OCT RNFL or GCIPL or GCC and the visual field. This schematic illustration, I'm using mean deviation. Visual field index is also a reasonable parameter with similar numbers. And in this range, you can measure change or abnormality in structure and function, and it corresponds, or it tends to correspond. And then below about 55 microns, there's a floor effect on the measurements with the OCT, and so you can't use the global measurements anymore of nerve fiber layer or macula in order to measure glaucoma progression. And you have to depend on the visual field, although local changes in the OCT, either the RNFL or the macular parameters, may still be detectable despite the fact that the mean overall nerve fiber layer has reached the floor. In a study of 127 people, 220 eyes, with a mean follow-up of 10 years, we found these data to be similar to what I just presented for cross-sectional studies. So in this longitudinal study, you're looking at all the data. When the retinal nerve fiber layer is thick, you can measure abnormalities and change primarily by structure. You reach a tipping point, and then there's a strong relationship between structure and function, and then you reach floor where the retinal nerve fiber layer is not changing, but you can measure change in the visual field by locally and by mean deviation and visual field index. And so this is the structure-function relationship in this longitudinal study. Let's talk about defining and measuring glaucoma progression with OCT. And so this printout is from CERIS, and the reason that I'm showing you this is it's the only OCT at present that has statistical tests for glaucoma progression. and in particular for the volumetric cube glaucoma progression measurement. So some OCTs just measure the circumpapillary RNFL, specifically the spectralis, and so it's measuring the circle that we developed over, well, about 30 years ago now, in order to assess the retinal nerve fiber layer over the entire ocular surface, just by measuring this circle around the optic nerve head. And it turns out that's a good parameter. It's very robust. But looking at a volumetric cube is better. And the reason is that it shows damage or progression outside of the area of the circle. And it also shows you the location of the glaucomatous abnormality and also the shape of the abnormality. Now, in this case, where you're looking at a progression map, you have the heat map on top, and then these, instead of being deviation maps like what you see on the single OCT printout, these are showing you where progression is occurring. And this yellow area is where progression has occurred once compared to baseline. So this is the first time it's showing up. And the red area is where the statistically significant progression has shown up more than one time. And so if the progression is occurring in a location and shape consistent with glaucoma, it gives you a high degree of certainty that true progression is actually occurring. And if you look at the parameters extracted from the circumpapillary circle, you can see the mean or average RNFL thickness, the superior quadrant thickness, and the inferior quadrant thickness. And what you see here is that progression can be detected earlier in this trend analysis in the inferior quadrant than in the average RNFL thickness. So yellow, again, is the first time that there's a statistically significant change. And then red is where the change has been confirmed. And so here you're seeing that this occurs at the 5th visit on the trend analysis for the average RNFL thickness, but on the 3rd visit for the inferior quadrant, and even later for the superior quadrant. In addition, you can see the statistical change in optic nerve head cup to disc ratio, and here you see the increase in cup to disc ratio, and it becomes statistically significant here at the 6th visit. And what's helpful is when you have a declining retinal nerve fiber layer thickness and an increase in cup to disc ratio, you have good internal confirmation that this is a real change, that your patient actually is getting worse and intervention may be necessary. And then this is the average, the retinal nerve fiber layer thickness profile. And so this shows you the thickness across the entire circumpapillary scan. And you have the baseline, the two baselines, and the OCT from that day. And here you see a statistically significant difference where the inferior quadrant has gotten significantly thinner. So all of these parameters allow you to determine whether or not change is occurring and whether or not that change is statistically significant. In other words, does it exceed the variability that would be expected of the measurements on this patient? You can also look at a table of the data if you prefer that to looking graphically as we just did. The spectralis gives you the thickness profile, and it shows you, the profile from baseline and compares that to the given day. But it's not a statistical analysis, unfortunately. And same thing for the RNFL thickness that's graphed out here. It's not statistical analysis, but allows you to see whether or not change appears to be occurring. And then the OptiView, which is another commonly used OCT device, allows you to see where change is occurring. And here you're looking at the macular map. So this is the GCC. The GCC is similar to the GCIPL on the Zeiss. OptiView implemented this first. It was a parameter that was invented by David Huang for the OptiView. And here you're looking at the RNFL, and you can see that the RNFL is thicker on the heat maps, the first three heat maps than the second three heat maps. And then again, the RNFL thickness profile. The OptiView does do a statistical test for the trend analysis of RNFL. And so if you look at this patient, you can see that there's this downward slope in a linear regression that's done for the trend analysis. Unfortunately, that can be misleading, as you see here, where you have a stable RNFL, and then something happens and there's a drop in RNFL thickness, but it's once again stable. So unlike the regression line, which looks like this patient is continually getting worse, something happened to make this patient worse, but now the patient appears to be stable. So just be careful when you're interpreting the information that the OCT is giving you. And I mentioned the floor effect that occurs with all of the OCT devices. And so in end-stage disease, you really can't count on the global measures of the RNFL or the GCC in order to detect progression in glaucoma. And you have to be careful not to be lulled into a false sense of security that everything's okay, because your patient is not progressing by RNFL or by GCC or GCIPL. It's not that they're not progressing, it's just that you can't measure it with the global measures on the OCT. Again, locally you may be able to detect change. There was a study that was run by David Huang that I was privileged to participate in, called the Advanced Imaging for Glaucoma Study. And there we looked at parametric glaucoma subjects as well as glaucoma suspects and pre-parametric glaucoma subjects and normal or healthy subjects. It was a multi-center study funded by the National Institutes of Health in the US. And this was a 10-year study, and we looked at a number of parameters. So one was predicting conversion in glaucoma, and by conversion, we meant people who are suspects or ocular hypertensives developing an abnormal visual field. So they started out with a normal visual field, developed an abnormal visual field, and as it turned out, the vast majority of visual field conversions, 82%, were preceded by an abnormal OCT. And there was, on average, a 2-year lag between visual field conversion and OCT abnormality. So the OCT abnormality was detectable approximately 2 years before the conversion occurred. And then we looked at predicting glaucoma progression. So these are people with parametric glaucoma, manifest glaucoma, and these are the data from that. So it turned out that the ganglion cell complex focal loss volume was the single best predictor of progression. In this study, we used the OptiView device, and here you can see the Kaplan-Meier curves showing that the progression was detectable much earlier on the OCT than the visual field, and that it occurred much more commonly in people who had an abnormal GCC-FLV than people who had normal GCC-FLV. And there was a relationship between the diagnostic group and the slope of the VFI. And this was the diagnostic group based on the baseline GCC FLD. So this is the baseline macular measurement. If it was normal, the visual field slope was 0.03. If it was borderline at baseline, then the visual field slope averaged 0.2. And if it was abnormal at baseline, the visual field slope averaged 0.44. So the baseline OCT parameters are good predictors of whether and how quickly the visual field is likely to progress. And then looking at progression of glaucoma in people with parametric disease, and also in ocular hypertensives and glaucoma suspects. So let's take that first. In suspects and pre-parametric glaucoma, you had a 2-year lag between progression by OCT and progression by visual field. And in the parametric glaucoma group, we found about a 1-year lag between progression by OCT and progression by visual field. So to summarize this portion of the talk, OCT detects structural progression about 1 to 2 years before visual field progression or conversion. Both the nerve fiber layer and GCC outperform the visual field in detecting progression in early glaucoma. And in moderate and advanced glaucoma, the nerve fiber layer progression rate decreases due to the floor effect. The GCC continues to detect progression well into moderate to advanced glaucoma, but it really has a very little additional bandwidth beyond the retinal nerve fiber layer. And it's important to monitor both the GCC or the GCIPL and the nerve fiber layer in addition to the visual field in assessment of glaucoma progression. So now I want to talk about some things that are happening in the laboratory. One is the use of visible light OCT. The OCT that we clinically use is near infrared. And another is adaptive optics for SLO and adaptive optics OCT. And then the last is artificial intelligence use in OCT for glaucoma. So let's talk about visible light OCT first. What this gives you is very high resolution. So higher resolution, you can see that the layers of the retina are more easily distinguishable with the visible light OCT than with conventional infrared, near infrared OCT like the spectralis. The spectralis gives a great image that we love to use, and retina specialists especially love the spectralis images, that you can see the improvement in image quality that you can achieve with visible light OCT. And then it's also possible to do retinal oximetry with visible light OCT, and because of the where the isospastic point is, you are able to do oximetry much more easily with visible light OCT than with near infrared. This is an example of images from visible light OCT. This is from the same individual. Visible light OCT, swept source OCT, cirrus OCT, and spectralis OCT. And it's obvious, I think, that the layers can be more easily distinguished using visible light OCT than using near infrared OCT. And in fact, not only can the layers be more easily distinguished, but you can see layers within layers. So this is the retinal nerve fiber layer and the ganglion cell layer, and this is the interplexiform layer. And you can see one bright, one dark, another bright, another dark, and another bright layer. So 5 layers in the interplexiform layer. And we're looking at that now in order to determine whether this is a good biomarker for glaucoma, and whether change in the IPL is something that we can follow, especially early in the disease. And then retinal oximetry, I mentioned is possible with visible light OCT using spectroscopy or spectroscopic OCT. Here you're looking at the strategy. So this is just cutting across the vessel, the vein and artery, and above and below. And this is what the B-scan looks like. And you take multiple B-scans and average in order to do the assessment of the O2 saturation. And so in the vein, in this case, we're seeing an O2 saturation of 0.59, and in the artery, saturation of 1. We'll be presenting at ARVO this year data showing the difference between healthy eyes and glaucomatous eyes in terms of O2 saturation in retinal vessels. This, again, may be another biomarker that we can use in assessing patients as an assessment of retinal function as opposed to retinal structure. Let's talk about adaptive optics briefly. And we used adaptive optics a number of years ago to look at the lamina curvosa, which is what you see on your left in a fly-through. It can also be used to look at the retinal nerve fiber layer, as you see here. There's a prototype device that's built by PSI. I should mention that the visible light OCT we are studying in collaboration with our colleagues at Northwestern University, and the device was designed and built by Hao Zhang, who is a wonderful collaborator. In terms of adaptive optics, again, PSI, which is in Massachusetts, built this prototype. And we used it to study the lamina and develop some algorithms for segmentation of pores and beams. We found that, again, differences between healthy and glaucomatous eyes, and published that a while ago. This was revolutionary when it came out 4 years ago. This is Ethan Rossi's work with adaptive optics SLO, showing visualization of retinal ganglion cells. So these little bumps here throughout, you can see these little bumps, and these bumps are each retinal ganglion cells. And we looked to see if we could do the same with our PSI prototype, and it turns out that we were able to reproduce his findings. But Don Miller went significantly further using adaptive optics OCT, and instead of little bumps, you can actually see the individual retinal ganglion cells in the ganglion cell layer. And he did this with a high-speed adaptive optics OCT and signal averaging. And so this was a single scan. This was 30 scans, and this is 137 scans. And so you can see that by signal averaging, you can vastly improve the signal-to-noise ratio or contrast-to-noise ratio. And here you see you get some diminishing returns as you go up higher on the curve. But just beautiful images that he was able to show with his group in this paper, also from 4 years ago. So retinal oximetry is possible with visible light OCT. Improved layer segmentation is possible with visible light OCT, and retinal ganglion cells can be visualized with adaptive optics OCT and adaptive optics SLO. And it gives us a revolutionary opportunity to characterize cellular changes in glaucoma in the cells that are damaged by the disease. It also, these advances offer the potential to identify disease and progression or response to treatment by structural and other than structural means. The last thing I want to talk about is artificial intelligence for OCT imaging. And artificial intelligence in the US was first approved by the Food and Drug Administration, by the government, for use for an ophthalmic application for identifying diabetic retinopathy. Artificial intelligence does extremely well in identifying a diabetic retinopathy from fundus photos. And this paper, when it came out, also was a big shock. Hard to believe it was only 3 years ago. And what this paper was looking at was identification of cardiovascular risk factors from retinal fundus photos. And amazingly, the group was able to look at predictive cardiovascular risk factors, including systemic hypertension and systolic blood pressure and major adverse cardiac events from the fundus photos. Things that we don't know how to do as human beings looking at the photos. And what was even more amazing was that the authors were able to identify gender using artificial intelligence from these retinal fundus photos. And again, we don't know how to do that looking at a fundus photo as human beings, but these algorithms are able to make that distinction. So we've been working with the IBM Watson research team in Melbourne, who are great collaborators on this project. And our hypothesis has been that the conventional approach of using known biomarkers like retinal nerve fiber layer and macular parameters like the GC-IPL or GCC is sacrificing something in terms of the analysis of the OCT, that it may be that approach is not sufficient to optimize clinical glaucoma assessment, and that if we use all of the data in the OCT volumetric scan, that we would be able to do better in distinguishing healthy from glaucomatous eyes and predicting future parameters that are of value in glaucoma. And so we called that a feature agnostic, data-driven approach, where we allow the algorithm to analyze the raw OCT data without any segmentation. So this was a paper that was testing that hypothesis for differentiation of glaucomatous from healthy eyes. And in fact, using conventional machine learning methods, the best AUC was 0.89, not bad. But using deep learning, we got a significantly higher AUC with this convolutional neural network. And you can look at a class activation map, which visualizes the areas that the algorithm is using in order to make its decisions. And you can see that the areas are very similar, or are the areas that we typically use clinically in this case. So the retinal nerve fiber layer, actually maybe the entire thickness of the retina, in the areas that are typically associated with glaucomatous damage, the optic nerve head, and the lamina curvosa. In the study, deep learning outperformed various conventional methods, even though no prior knowledge was applied. And so we trained the algorithm and then tested it on test sets, and the class activation map showed that the algorithm used relevant structures, or what we believe are relevant structures for glaucoma diagnosis. And we felt that this proved the hypothesis that the agnostic data-driven approach works and is potentially powerful. We then took a similar approach in terms of predicting visual field performance using the OCT. So just using OCT data, could we predict what the visual field index was going to be from the corresponding OCT scans? And so these are the demographics and the data that we used. And again, the conventional methods did not do quite as well as the deep learning method. So these are the conventional machine learning methods. The best we could do was 0.74. But here you can see that the deep learning method did quite a bit better. Using the raw data, the overall estimation error with deep learning was 2%, whereas using conventional machine learning methods with typical OCT biomarkers, it was 5%. And newer work is focusing on looking at the local abnormalities or predicting or describing the local abnormalities in the visual field using the OCT data. And that's what you see here, where these are the actual performance on the visual fields, and these are the estimates from the OCT data alone. Finally, we tested whether we could predict what retinal nerve fiber layer thickness would be in the future from a set of retinal nerve fiber layer thicknesses from OCT. So we took 3 visits and determined whether we could predict what the retinal nerve fiber layer would be on the 4th visit, and we compared that to the GPA. These are the input data. And what you see is that deep learning, lower number here is better because this is the mean absolute error. Deep learning did better than the GPA in all groups. And the disease status appeared not to affect the performance. So the knowledge-based approach was outperformed by the agnostic data-driven approach. There's untapped data in the OCT volumes, and we're just beginning to understand where to look. The agnostic data-driven approach may also uncover new insights in glaucoma biomarkers and pathogenesis and may improve clinical patient care going forward. I want to acknowledge my collaborators, especially David Huang at OHSU, who ran the Advanced Imaging for Glaucoma study. My collaborators at IBM, who I mentioned before, Hao Zhang at Northwestern, and of course Jin Fujimoto at MIT. And the great group of people that I get to work with at NYU in our Advanced Ophthalmic Imaging Research Laboratory. Thank you very much.
Thank you very much, Dr. Showman, for that very, very interesting and informative talk. The second part of the talk on the recent advances was mesmerizing, to say the least. And we look forward to all those inventions which you're leading. I would now request Dr. Pandav to please lead off the discussion.
Thank you, Dr. Chandrima, and thank you, Dr. Joel. That was really, I think, the wonderful talk that we have ever listened on OCT, especially what we are expecting to see in the in near future. So, do we have any questions from online audience? I think to begin with, I'll just I think I'll start from the first part. Basically, you said that when doing the OCT, there's a kind of a tipping point at about 75 microns, and then down below at about 55 microns, then of course the things change again. And that is a segment which is more or less kind of have some linear relationship, some structure function relationship. And above that probably is because the functional reserve, and below that is because the floor effect is there. So is there a way to diagnose glaucoma from the OCT that we normally use, above this 75 microns, the tipping point? So that, in other words, what that means is that we are still in the green zone, perhaps, as far as OCT is concerned, and things are still happening. So what do you, is there a way to find out glaucoma in that zone? And also, what do you, recommend that what we should be looking for, particularly if that's the situation?
So thank you. Those are great questions. So when I'm looking at the OCT printout, I look at the heat map of retinal nerve fiber layer thickness because it shows me the pattern. And as ophthalmologists, we do a lot of pattern recognition, and it shows us where the thinness may be. Even more so, I use the deviation map, which allows me to see the location and pattern of the difference from the population. And so somebody can have a retinal nerve fiber layer thickness average that's well within the normal range, but have a focal abnormality on the deviation map. And so that it's important not just to use the global parameters, but you know, when we do these studies, we tend to use the global parameters in order to make these sorts of comparisons. And then, you know, we do a deeper dive into the data to look for differences or things that would be helpful. But clinically, we have all of this information presented to us. And so the deviation map can be really helpful. The other thing that I find very helpful is the RNFL thickness profile. Because if the profile differs from what's expected, right? So normally you have these two humps in the superior and inferior area. But if somebody has a flattened hump, even if it's still within the normal range, it should make you suspicious that there's some abnormality in the retinal nerve fiber layer in that individual. And then you also have the data on the optic nerve head that can be useful. Many people like to talk about the MRW, the minimum rim width, and that's another parameter to look at. So I think that we need to be careful to look at the focal parameters in addition to the global parameters when we're evaluating the OCT. The other thing that we need to be careful to look at is the quality of the scan. So whether or not the signal strength or the quality index or whatever the particular machine uses as its quality parameter, to make sure that the image is of good enough quality to analyze. Because very often, you know, you hear talk about red disease. So red disease is a term I think Richard Lee at Bascom Palmer developed. And really what red disease usually is a bad scan where the segmentation algorithm has failed. And so you're looking at a measurement that isn't accurate. The other area where you get that sort of abnormality that can make you think that there's glaucoma is in myopes. So people with high myopia or even moderate myopia will have a thinner nerve fiber layer because their retina has more area that it needs to cover in a longer eye. And so for them, it's normal to have a given nerve fiber layer thickness where it's outside the normal range for somebody who's less myopic.
I think one related question that comes to my mind is that when you are still, you know, above the tipping point, even the normal individual, they would have a, you know, some kind of variability. You know, like myopia example you gave, even normally the retinal fibers would be thin, but even you know, even otherwise normal individual, with the disc and the configuration of the optic, you know, arrangement of nerve fibers around the optic nerve head also varies, you know, in different individuals. So does that kind of impact the interpretation of the OCT, and how do you kind of look for that in a given OCT scan? Perhaps, you know, there might be the normal variation, variability, which can be confused with glaucoma or normalcy.
Sure. No, absolutely. So variability in the population plays a big role. And I think that that is something that we need to be careful about so that we don't overcall disease. But the deviation map is very helpful in terms of identifying defects or abnormalities that are glaucomatous as opposed to due to something else. And so that's why I talked about the clinician looking at the location and shape of the defect, of whatever doesn't correspond statistically to the normal range. And so the deviation map is a statistical test to see which points are outside the normal range in your OCT volume. For instance, in a myope, you'll have abnormality typically nasal to the disc. And that's not where you typically see glaucomatous abnormality, especially early in disease. As an observer, as a clinician, we need to interpret the information that the OCT is giving us. It's not necessarily digesting all that information for us and giving us a single number that we can use. It does give you that number, but that might not be the whole story.
Joe, does the size of the disc influence the OCT findings?
I love that question. And the reason I love it is there was a big debate about this about 20 years ago. When I came up with the idea of the scanning circle, and the reason that I thought that it would be good to have a fixed size scanning circle was that I viewed the optic nerve head as as if it were a point source. And so all of these fibers going out through the optic nerve head. And so if we scanned at a fixed distance from the center of the optic nerve head, we should be able to compare across the population and come up with a better way of determining whether or not there was an abnormality. There is some influence on the number of axons associated with disc size, but it's not enough to warrant a variable circle size. So by having a fixed circle, unless you have a huge disc or a tiny disc, you should be able to get a good measurement that's comparable across individuals and not have to worry about the measurement being corrupted or affected or confounded by the disc size. And so that, I think that answers your question.
Thanks for that, Joe. Sorry, I don't want to hold all the time. Do the panelists have any want to ask any question? I'll put the panelists. Do you consider the inter-eye differences also when you are doing the OCT? Any of the panelists can also actually respond to that.
Would you like me to answer, or do you want the panelists to answer?
Yeah, GC, do you have any comment on that kind of situation like we look at the inter-eye differences, for many things. So do we look for the OCT also?
So before I get there, Pandav, if you allow me, I want to just address the issue of the structure function loss, the structure preceding the function. I think one of the most important things there is what kind of a function are we looking at. We have been limited with the 24-2 program or 30-2 program in the visual fields and have not concentrated enough on the 10-2 program or the resolution of the 6 degrees versus 2 degrees in the 24-2 versus 10-2 program. So if you actually end up doing the 10-2 program in all those cases where, as Joel rightly pointed out, I think that's the most important thing to learn. Don't look at the averages, but look at the localized areas where the damage is there. And then based on the suspicion that you have on the OCT, go back and do a 10-2 program. Then probably a large number of what we typically call the preperimetric glaucomas would have a significant functional damage loss also, I think is the point that one needs to make. I just wanted to reiterate that particular point about the structure function correlation bit. As far as the inter-eye asymmetry is concerned, I think it's a very important point for more than one reason. Actually, before going to the inter-eye asymmetry, probably you need to also pay attention to the fact that in early glaucoma, the damage is usually in only one hemisphere rather than in both hemispheres. So I would stress on the fact of looking at the asymmetry between the superior versus inferior, whatever structure and function like the glaucoma hemifield test that you are seeing, And then you need to probably look at the inter-eye asymmetry also. So I typically believe that there are 4 hemispheres that the patient presents, superior, inferior of right and superior, inferior of left, that need to be compared. The inter-eye asymmetry from the point of view of difference in the disc size, especially if you're focusing on the cup disc ratio clinically, would be very important. If you have a difference in the refractive error, how would that influence the nerve fiber layer assessment is the other thing that one needs to think of. So I would stop there and let others comment.
Dr. Pandav, can I ask him something?
Yes.
Dr. Showman, you told us that this oxygen saturation thing would be the thing of the future, and maybe it's coming up. But at the current level that we have the machines, the OCT angio, do you think at the current level, it can detect changes earlier than the other things? And should we focus more on that to detect the functional change at the ganglion level?
So at this point, I don't think OCT angiography is giving us information that will allow us to take better care of our glaucoma patients, or at least we don't know how to extract that information or what to do with it. It seems like the OCT angiography is showing us what's already happened and what we could already measure with the RNFL, and it lags behind. So the loss of RNFL seems to result in a decrease in vascularity, and probably because you don't need to feed that tissue so much anymore, and so you have a different decrease in vessel density. We are now looking, there are 2 groups that I'm involved with, but I'm sure that there are many globally, looking at various new parameters for OCT angiography to try to extract more useful information for glaucoma management. But right now, I think the clinician in practice really can't do a better job taking care of glaucoma by using the OCTA.
Joel, don't you think the similar thing can happen with the saturation map as well? Because the demand is less, so the saturation won't be, will also be like it will go down in the sense that because.
Yeah, it may well be. It could be that you would be able to measure. First of all, it's going to fluctuate more, but it could be that you can measure earlier changes or do some kind of a stress test in order to get the information that we desire out of the oxygen saturation. Right now, it's just, can we measure oxygen saturation accurately? And we'll have to figure out how to make it a useful tool for clinical use. If I can just comment on the cup to disc and disc size item that GC mentioned, one of the nice things that we noticed very early on is that if somebody has asymmetric cupping and is a glaucoma suspect because of that, very frequently, if they don't really have glaucoma, they will have symmetrical nerve fiber layer thickness. And that's a really good parameter to eliminate somebody as a glaucoma suspect. So it allows you to follow that patient less intensively and also allay their concern about getting disease.
I think that would be very useful clinically, because many times you have asymmetry and you wonder whether it's glaucoma or not. So I think that tip would be very useful.
Can I ask one question?
Yes.
Can we, as you said, the GCC is also very important. So can we treat patient pre-parametric cases just based on the GCC diagnosis?
Yeah, I think the time has come where if you're confident that the abnormality that you're measuring is glaucomatous, even with a normal visual field, that it's reasonable to treat based on the OCT, whether it's the GCC or the RNFL or both. And very often you'll see matching abnormalities in the GCC and the RNFL. I think both are very good parameters. And in the studies that we did, while the GCC did better, it was only slightly better than the RNFL. Both did better than Fields.
There's one question relating to this, is how often should we repeat the OCT when we are treating pre-perimetric glaucoma?
In my opinion, if I have somebody who has glaucoma and it's stable, or I think it's stable, I will test them every 6 months. If I have somebody unstable, the frequency could be whatever they need. But for a stable patient, I do every 6 months if they have glaucoma. If they're a suspect, it's less frequent.
And for a patient who is progressing, to detect progression, how often would you repeat the OCT?
So it's good to have a set of OCTs early on that you can compare to, because the comparisons that we make are both event-based and also trend-based. And so for the event-based comparisons, you need a good baseline. And so, I might get an OCT every month or two if I'm suspicious that somebody is progressing, in order to have a good baseline to follow. But it's uncommon, I would say, for a patient, in my hands, for a patient to need to have that frequency of OCTs. In general, if I have somebody who is progressing, or I'm suspicious that they're progressing, you don't need a lot of tests in order to confirm that that progression is real. That's one of the nice things about OCT as compared to visual fields. The variability is less. And especially if you have both the visual field and the OCT, you can, it may be one visit where you're able to say, okay, my visual field is worse, my OCT is worse in a corresponding way. I think this is real. Maybe you'll repeat it once if the choice is to go back to go to the OR. If it's a choice of adding a drop or doing a laser SLT, it may be that one evidence of progression is satisfactory. But it's not like the old days where you needed to do 6 visual fields to confirm that the visual field change that you're measuring is really real. If you have corresponding change by structure and function, I think that gives a high degree of confidence that that change is real.
Thank you very much.
Hear what the panel has to say about that.
Dr.
Unmute yourself,
please unmute.
Can I ask one question at this point of our discussion?
Yes, sure.
And Dr. Suman, we are doing the OCT angio. Can it be of any help to find out the etiological relationship with the pre-perimetric glaucoma and the changes in the macular area, etiologically, vascular factor?
Yeah.
Does it have any bearing?
Yeah, I don't think so. If there is a way, I don't know how to do it. So it may be that the information is there and we just don't know how to extract it yet. But in terms of determining whether somebody has a vascular etiology to their glaucoma, I haven't found OCTA to be a good discriminator. And I don't recall seeing any articles that suggest that OCTA can define the etiology. Maybe I've missed it in the literature, but I don't recall seeing that.
Thank you.
Can I ask a question, Dr.?
Yes.
So in your talk, you mentioned about the progression, the OCT progression and the visual field progression. Especially in perimetric glaucoma, the event interval between both is 1 year. Is it constant, or is there any variable factor that depends upon any risk factors like IOP or any other cardiovascular myopia, something like
Right. So I think you're talking about the, on average, that the OCT was able to detect progression a year earlier in people with parametric glaucoma than visual fields progression. Is that what you're asking about?
Yeah, yeah, yeah.
Yeah. So that, it's an average of a lot of subjects. So with some patients, you're going to be able to have a longer interval between the time that you have your OCT detected progression, and some it's going to be a shorter interval. In many patients, you can detect it, very close in time. So we haven't parsed out whether things like cardiovascular risk factors or other IOP or other parameters were relevant in the earlier detection by OCT or later detection by visual field. So it may be that those factors do play a role. We just don't know at this point.
Another question. So you, in the initial talk, you mentioned about the tipping points. What's the clinical relevance of tipping point? Can you elaborate a little more? The tipping points for superior, inferior, nasal, and temporal part.
Right. So those numbers are in the paper, and they were on the slide for the different different quadrants. The utility clinically, I think, is that if you have somebody who has, let's say you're seeing them for the first time, and they have a thin RNFL, but they don't have a visual field abnormality yet, it's not surprising that they could have real glaucoma and yet have a normal visual field. And so I think that it allows us to use the OCT data more fully in order to treat the patient. The other aspect, I guess, is that if you are very suspicious that somebody has disease, but they are pre-parametric, and they haven't reached that tipping point yet where they also have a visual field abnormality, you can actually detect progression on the visual field with a normal visual field. And so a series of normal visual fields in somebody who's progressing on OCT may show corresponding progression on the visual field if you look at the GPA. And so that, again, would be very strong evidence that this person actually is deteriorating, even though they have a normal visual field. And so it helps to explain, well, they have glaucoma, but how could they have a normal visual field? Well, it's because the visual fields aren't sensitive enough and they're highly variable. And so they haven't hit a statistical probability that their visual field is outside the normal range, or that they have scotomas that show up on the field. It's not that they don't have abnormalities, it's just that we can't detect them by the visual field test that we're doing. Like GC was saying about the 10-2, if you do a 10-2, you're going to pick up finer abnormalities that are central, but then the patient has to do a 10-2, and you don't have statistical testing to determine whether or not that 10-2 is getting worse. So that's what's held me back from doing 10-2 primarily, because I can't do GPA on the 10-2.
Thank you.
Any other questions?
The normative database of the OCT starts at 18 years. How useful would it be in a patient below the age of 18? And
I think it would
how would you go up?
Yeah, I think it would be very useful for clinicians. I think that, industry tends to do things that are going to be good for industry. And the market is a lot smaller for taking care of kids. So I think that that's probably the reason that we haven't seen a pediatric normative database incorporated into one of these OCT devices. On the other hand, there have been a number of studies that have shown what the normal parameters are in children, and you could compare to those parameters instead of having it in the machine. What we sometimes do to trick the machine is put in, you know, an age of 18, so we can look at least compared to the normative database for, you know, if this person had been 18. But it's frustrating that there's no pediatric normative database at this point.
You talked about the visible light OCT. So how does it work? I mean, are you doing the like multiple wavelengths at the same time or one after the other? And this kind of sounds somewhat similar to the sweat source OCT. So how do they differ? Because the picture you showed was just fantastic and mind-blowing, the kind of resolution that you get with the light, you know, visible light OCT. So I'd like to have a little more detail on that.
Right, it's a great question. So swept source OCT is near infrared, and you want the bandwidth to be broad in OCT so that you have high resolution. And so with the swept source OCT, you're sweeping through a number of bandwidths, a number of wavelengths rather, across the bandwidth, and then collecting data on each wavelength. And that's what gives you high resolution and the same sort of ability as with spectral domain to not have a moving mirror to give you the reference plane. The visible light OCT, the one that we're using is a spectral domain device. And instead of being in the near infrared, it uses shorter wavelengths. It has a broad bandwidth, but it's in the visible light range. And because of the shorter wavelength, you're able to get higher resolution. So it's simply a function of the wavelengths that are being used. The basic principle is the same, just like you said. But it's not a swept source, it's a spectral domain.
Thanks for that. I think that another question was, I was wondering about the artificial intelligence. So if you're using like agnostic data, you know, that kind of, it looks like is giving you much more information, something that you can't actually get going by the clinical parameters or clinical biomarkers. Can it also predict IOP?
We haven't looked at prediction of IOP, so I don't know the answer to that question. We haven't designed an algorithm for that.
Predict a lot of things, you know, like even the sex of the the person. So
we tried with OCT to see if we could determine gender or sex, and we couldn't. Maybe we didn't have enough data, or we didn't write the right algorithms, but we couldn't reproduce what they could do with fundus photos in terms of predicting sex.
Yeah, I think so. That was my next question in terms of glaucoma. I mean, if you're using CT, OCT, or if you're using a fundus photo for diagnosing glaucoma on the OCT and the AI algorithms, so is there any difference? Have you kind of some experience on that? Or?
Well, actually, I think the person who's done the most in that realm has been Felipe Medeiros, although Pierce Keenan has certainly done quite a bit. So there's a really good group at Moorfields, and there's Felipe's group at Duke, and there are some other groups around the world that are looking at this closely. And the findings so far on fundus photos have been very encouraging, even to the point of predicting retinal nerve fiber layer thickness. So that's really interesting, right? That you could take a fundus photo and predict what the nerve fiber layer thickness is. So I think that we'll see a lot more utility developed in the AI realm for the various imaging techniques that we're able to use. You talked about, you mentioned the agnostic approach, data-driven approach that we've been using, and again, that was an attempt to make fuller use of the data that we were acquiring from the OCT than simply segmenting the scan and looking specifically at the layers that we think are important. But I think that we'll see a lot more on artificial intelligence for OCT, maybe even HRT, the old confocal systems, and for fundus photos, which are a lot cheaper to obtain than the OCTs. Can I just mention one more thing? So the reason that the group that I was associated with became involved in OCT for glaucoma is that it was a way of doing objective quantitative measurement of the tissue in a non-invasive, quick and easy way, easy for the patient. But if you can get objective quantitative data from a fundus photo, you can get the same sort of expert assessment of a patient without the subjective input that's necessary from an expert. And so it may be that fundus photos really grow again in their utility.
Can I ask one question, GC?
Yeah.
When will you call an abnormal OCT not indicative of pre-perimetric glaucoma? Any pulse that you would like to share?
Yeah, so I always look at the pattern of abnormality. And so like I was mentioning before, I'll look at the deviation map and see if the areas that are abnormal are in areas typically associated with glaucomatous abnormality. So are they superior and with an arcuate band towards the macula, or inferior with an arcuate band of abnormality? And so the shape and location of the abnormalities are really important in determining whether or not somebody actually has glaucoma, or if it's some other abnormality that is causing the OCT to be outside the normal range. And so that I think is really important. And then I'll look at the RNFL thickness profile. And again, I'm looking at that map of abnormalities by looking at the profile, but the profile also shows me the depth of the abnormality, which I can't get from the deviation map. As soon as you're outside the normal range, it's going to be red on the deviation map. But the RNFL thickness profile will show you how far outside the normal range. So is it just skirting the abnormal range? Is it because the peaks are, of the RNFL thickness are closer together or further apart than for most of the population? There are a lot of reasons for anomalous scans where somebody's really normal, but they're showing up as being abnormal. And so I look at all of those before committing somebody to having an abnormality. Finally, if I'm not sure, I'll follow the patient for change. And I'm going to follow them for change anyway, I guess, but I'll reserve judgment until I see whether or not changes actually occurred. And that is very frequently how I end up following people who are highly myopic. Because it's very hard to tell sometimes whether the abnormality is just from the myopia or if it's glaucomatous.
Sometimes it is a tilted disc.
On that note, I'll just ask a
CD
question.
ratio, what we see clinically may not be matching with the OCT findings. So how to go with it?
Right. I think that the OCT helps to drive you back to the patient also. So as a glaucoma expert, you're able to say, okay, well, the OCT shows this abnormality. I should see this thing in the disc, let's say. And if you don't see it, if it doesn't match, either the OCT is wrong or the abnormality is too subtle. So if it's that subtle, maybe you can follow it and see if it actually develops further. And I think that we have to use our judgment as clinical experts as well. The advantage of OCT, though, is that for a non-expert observer, it can bring them up to the expert level. And so, maybe these very subtle cases where, we're unsure whether the OCT abnormality is glaucomatous, are, there are cases that we need to think about and be concerned about, but they're fortunately the vast minority of cases.
A basic question from budding glaucomatologists.
Chandrima, before you go there, I want to
you would like to
discussion on this point a little bit.
Yes.
Yes. Carry on.
Yeah. I agree with all that Joel Schumann has said, and it's very, very important. The additional points that I would like to say is that when you say that you can get an average ophthalmologist, the expertise of a glaucoma specialist with OCT, the average ophthalmologist should understand all the limitations of OCT.
Exactly.
And the average ophthalmologist should have the concept of clinical correlation and what's the possibility of a given patient having glaucoma with this abnormal OCT. And that will come from complete clinical examination. So you cannot go by just the OCT and say whether the patient has glaucoma or not. So I think that's the fundamental thing. A little more detail into that, what I would say is, he talked about looking at the optic disc when you're suspecting a tilted disc. I will reiterate the point of repeating the visual field with 10-2 program. Even if you don't have GPA to make a one-time diagnosis, 10-2 program is invaluable. You cannot make diagnosis of preperimetric glaucoma without doing the 10-2 program. The other fundamental thing to remember when you are diagnosing preperimetric glaucoma is to realize that in early glaucoma, if the patient has an advanced cupping and a large 40 pressure, you don't need OCT to make a diagnosis. In the early preperimetric glaucoma, you need to realize that the damage is usually present only in one hemisphere. So that damage that you see in the OCT is not statistical, but what you see in the detail of the deviation map and the heat map that Joel talked about, you need to pay attention to that detail. And whether that would correlate with what you see clinically in the optic disc or not is what you need to see. So I think we need to have either a structure function or a structure correlation to call it as a preperimetric glaucoma. So to call it as a structure correlation, you need to look at the optic disc carefully. You cannot use the OCT in diagnosis of preperimetric glaucoma by dumping your clinical examination of the optic disc or its photograph to dustbin. So for a preperimetric glaucoma diagnosis, structure or structure function correlation is needed. And from that perspective, you have to look at the optic disc and you have to develop the skill of looking at the optic disc if your 10-2 is normal. I think that's the point that I would like to make. And when you say that the average ophthalmologist is coming to the expert level, his knowledge about the pretest probability and whether the given patient has the pretest probability in the low range or high range, whether it's a red disease or indicative of disease, is once again not within the realm of a general ophthalmologist. We need to teach them that also while we give them the expensive OCT.
Okay, I think
that's very well summed up, sir. Thank you very much.
So that means what you are essentially saying is that the optic disc evaluation and those the clinical skills are still very much relevant, so Joel, I think probably we are running out.
Yeah, I'll just take one basic question which came from budding glaucomatologists. They're asking that would you give more importance to RNFL or to GCC?
They're both important, but I find that the RNFL, for me, helps to identify the abnormality better than the GCC. I see a lot of artifacts on the GCC that I don't see in RNFL, but it's like choosing between your children, right? Which one do you love more? They're both great.
Thank you very much.
I think we are almost nearing the end of the, this.
Yes, we're almost at the end of it.
I'll just take on, I think, where the GC left off, with the relevance of clinical examination. Of course, this is very important. But I think if you look at the advances that are happening in the OCT, the adaptive optics, artificial intelligence coming in. Joel, do you think we are heading in a direction where clinical examination would become irrelevant?
No, I don't. I think clinical examination is very important. It may be hubris that, we think that we can do the best job. But I think that it is absolutely true that we as ophthalmologists need to have excellent clinical skills. We need to be able to examine the patient, to interpret the nerve, to listen to what the patient has to say. Every patient is telling you their story. And so I think that it's really important that we have the clinical interaction with the patient. What OCT does, I think, is that it gives us an objective quantitative parameter that we can follow over time and compare to the population that allows us to make decisions, helps us to make decisions about whether or not somebody has disease or whether or not they're getting worse.
Thanks, Joel, for your wonderful talk. And I think you have please summed up in the end that every patient has a different story and every disc has a different story. So I think with that note, I'll hand over to Chandrima for, I think, the final thanks. And
thank you.
Thank you very much.
Thank you. Thank you very much. I place on record on behalf of the Glaucoma Society of India our honest appreciation and gratitude for Dr. Joel S. Showman, not only for the wonderful talk, which beyond our imagination mesmerized us, but also for the time that you've given this evening to the Glaucoma Society of India and its members. We appreciate this from the core of our heart. The responses on the YouTube and the Facebook are phenomenal. And I'm sure at some point of time you would look at them and actually feel good that you were here with us this evening and actually inspired us and enlightened us and mesmerized us. Thank you very much, Dr. Joel S. Showman, for being here with us this evening. Next, I place on record my very sincere gratitude and thank you to the past presidents of our society who have been the stalwarts and are known worldwide for their acumen in glaucoma, and they've always been at the helm of events and led the Glaucoma Society always from the front, each one of them. I thank you very much for being here this evening. I thank Dr. Pandav, the president, for so wonderfully leading off the entire program. Thank you very much, sir. And last but not the least, I thank the treasurer. Without the treasurer, actually, we can't do anything. She's the most important person to sign the check for everything. So thank you very much, Dr. Mayuri. And thank you, Mr. Bhageshwar, for having this entire thing so beautifully done on a virtual platform. Thank you very much once again. And thank you, all the audience, the viewers on Facebook, tremendous number of viewers on Facebook and YouTube, and those who joined us virtually, the members of the Glaucoma Society of India. Thank you very much. And we look forward to bringing you once again Dr. Joel S. Showman, most probably in a physical form at one of our conferences in the near future. Thank you very much. Thank you very much. Thank you.
Thank you. Thank you so much.
Okay, good night.
Thank you.
Good night. Good night.
Thank you.
Wonderful.